All right, so we'll start recording and we'll go to fluid electrolyte. So I'm going to, today's lecture is about fluids, electrolytes, and ABGs, the interpretation of the ABGs and the fluids and electrolytes. So the slide talks about the distribution of fluids in the different compartments and the percentage of body weight in each age group, how it's different in when it older adults versus the infant. The majority of the infant's weight will be fluids, and the distribution of fluids also in the different compartments like intracellular, the extracellular, which is available now in two different subcompartments, which is the intravascular and the blood and the vascular system, and the interstitial system or interstitial space. Interstitial, which is between the blood vessels and the cells, and then we have a transcellular space or compartment. So the fluids are located within the cells. This is the intracellular fluid, ICF, and most prevalent cation inside, this is intracellular now. So we're talking about the electrolytes, fluids, and electrolytes. So electrolytes, or which one will be more prevalent in the cell? Intracellular cation will be, is it sodium or potassium inside the cell? Mostly. We'll have both, but what's highest concentration inside the cell?
Potassium.
Potassium. So we have more potassium as an electrolyte inside the cell more than the sodium, which makes sense when the RBCs are destroyed. So the destruction of the RBC is going to release potassium in the blood or in the vascular system. So patients who receive lots of or multiple or frequent blood transfusions and they run into more frequent and speedy destruction of the RBCs, and they will may develop the hyperkalemia from that, from the destroyed RBCs and potassium released in the bloodstream. Extracellular fluid, ECF, about 20% of body weight. Yes.
So if the RBC is destroyed, what will happen?
Then more potassium is going to be released because potassium is more contained or present inside the cells. So destruction of that cell, of the cell will release its content. One of them is the potassium. So most of the potassium is present and or available inside the cell, intracellular. So we have inside the cell, we have both sodium and potassium, but potassium will be more than sodium. So the extracellular fluid, ECF, which is interstitial and intravascular, the interstitial, it expands and contracts. In other words, that the patients, when they lose fluids, they become dehydrated, and more fluids is going to be seeped or leaked through to the interstitial space, and that will result in edema or swelling. An intravascular space, which is the plasma. Now, the transcellular fluid, the third compartment, so fluid's not inside the cell, it's not out of the cell, which is extracellular, which is in the interstitial or vascular. There is also small amount of fluids, about 1 liter of fluid, available or present in different spaces. Like, what type of these fluids called transcellular fluids?
Is it the CSF?
Yeah, that's the CSF, one of them, cerebrospinal fluid. Cerebrospinal fluid is small amount, very small compared to so this is in comparison to the intra or extracellular fluids, it's very small, tiny amount. It's all combined in one max of 1 liter of fluid, 1000 ml. So CSF is one of them. Fluids also in the GI tract, fluids in the lungs, or in the what is called the pleural space. We have a small, tiny amount between the visceral membrane and parietal membrane around the lungs to prevent these two linings to rub, against each other. Otherwise, we will have a very experience pain or chest pain, which is called pleurisy, if we don't have this fluid. If this fluid is gone, it's not there, then these two lines is going to rub against each other when we inhale. With each inhalation, we will experience pain called pleurisy. So the presence of that small amount of fluid, almost about like 50 mLs of fluid between the parietal and the visceral linings around the lungs, that will prevent the pleurisy. So this is also part of the transcellular fluid. So we have the CSF, GI, pleural space, synovial fluids in the joints, peritoneal fluid in the abdomen. So the mechanisms that will govern and control the fluid electrolyte movement between these compartments, which results in homeostasis between the fluids inside the cells and outside the cells, the transcellular fluids or space, that all the this large amount of fluid will be in all these compartments will work in harmony, so that's where there will be homeostasis. So these are the forces that will govern and control the fluid to maintain it within defined limits and to result in a state of homeostasis. So the osmosis that will control the movement of, so we have two major components here. Either the force is going to control the water itself, or it will control the molecules, solutes, molecules, all types of molecules, proteins, electrolytes, and so forth. So the osmosis only can govern and control the movement of the water. So the osmosis will move, so movement of the water between two compartments by membrane permeable to water, but not to a solute. So only can govern and control the movement of the water between or against that membrane. But the diffusion, it's responsible for controlling, or it governs and control the movement of the molecules or the solute. Like when you dissolve or try to add like a spoon of tea, of the sugar, or you add some salt or sugar to the water. When you mix it, it will be distributed in the cup of that water by the diffusion. And then we have facilitated diffusion and then active transport. Here is just to clarify and make sure that we understand what is hypo, what is iso, and what is the hypertonic solution. The hypotonic solution, so to weed out or to eliminate all these confusing, factors, and try to make it clear about, how to understand, so we can understand the difference between the different types of solutions in terms of the strength, because when the solutions, it's the osmolality of the solution. Osmolality means, or osmolarity means the concentration of the solution in response to or in comparison with the concentration of the cell. So let's see that this is the RBC, red blood cell, and this is the solution. you're going to infuse this solution into the bloodstream. So let's say that this is the bloodstream and this is the cell. This is the RBC. Now, if this is a hypotonic solution, so the concentration of this solution will be less than this, because what makes the concentration of any of the cell of the bloodstream or plasma or concentration of the fluid is two things. Either it's hypotonic, which means that we have more water than the solute, the molecules. Hypotonic means we have less molecules and more water. Isotonic, we have both equal in terms of we have a balance between them. Hypertonic solution, which means the solution has more molecules, more particles, more solute than the water. So if this is a hypotonic, then which means it has more water than the molecules, so it's going to release that water into the cell, and the cell will swell and become edematous or swollen. If this is isotonic, which means that there is the balance between the molecules and the solute, so the concentration is equal to the cell, so there will be an exchange between both of them, but it's not going to affect. So the bloodstream or the plasma and the cell, they will have equal, or they have constant transmission or exchange of water and solute, but with no changes. The cell is not going to shrink or swell. So it's not going to release fluids or absorb fluids or take fluids from the isotonic solution. But here, because it's hypotonic solution, so it has less molecules, it has more water, so that more, the excess of the water is going to enter the cell. And that's why the cell is going to swell and may burst or die. Now, on the other side here of the extreme or the hypotonic and then hypertonic, which means that the fluid or the solution, it's highly concentrated. It has lots of molecules, lots of solute compared to the amount of fluid or water, right? So it's concentrated. So which means that it's more molecules than the water. So it needs some water. It's not going to get it from the cell. It's going to absorb and take these extra water from the cell to make it, because every media try to reach the homeostasis on the expense of the other, right, on the other cells. So this solution wants to make, to be balanced, or to reach that, balance, or, objective is, for the homeostasis, once more water. So I'm going to get the water from the cell. And that's why the cell is going to shrink, because the fluid or the water is going to exit the cell to the hypertonic solution. So hypertonic solution, we expect that, if you give hypertonic solution, is going to get the fluid from, or the water from the cells, because it's over concentrated or highly concentrated compared to the cell. So hypotonic solution fluids will get into the cell, and hypertonic fluids will get out of the cell and result in shrinking of the cell. These are examples of hyper, and isotonic. Factors or forces that govern the movement of fluids between compartments. We went over this and we said osmotic, hydrostatic, oncotic. The osmotic and hydrostatic, there are some similarities between them, which is basically the forces based on the concentration, which is the solute, and the force within the fluid because of the pressure. So two things. Osmotic is the amount of fluids, it's the concentration, the amount of solutes or molecules. The hydrostatic, it's the pressure within, which is the volume, which will result in more force to push the fluids out. So hydrostatic flow is going to push the fluid out. Oncotic fluid will bring or pull them in because of the molecule of the what is called colloid or proteins. It's called oncotic pressure. Osmolarity or osmolality, which is the concentration of the fluid. Here we more concerned about the plasma, and we focus on the plasma. So the plasma osmolarity or osmolality for the plasma is supposed to be between 275 and 295. So when the osmolarity is over 295, which in other words that it's concentrated plasma, in other words that we have more molecules, more solutes than the water, so that's a water deficit. And when it's diluted or less concentrated, then we have a water excess, fluid overload.
So Dr. Mickey, when we have more than 295, we have more molecules outside the cell?
No. This is the plasma osmolarity.
Okay.
This is the plasma osmolarity. This is the concentration of the blood. This is how the plasma is concentrated or diluted. So when it's within range, we have a normal distribution of molecules, proteins, RBCs, and so forth. Then the range is supposed to be between 295 and 275. If it's over 295, and some textbooks they go with 300, it's over this number, then it's concentrated. In other words, that there is less water than the molecules. So there is a water deficit. Less than 275 is diluted. We have more water, so that's a water excess or fluid overload. So I'm sure that you saw these slides from Patho. It's just, choose a few, review them. So you will review or understand the factors that control and govern the fluid movement between compartments. Especially we focus, the more prevalent problem with fluids would be either dehydration or edema, and mostly edema of different forms, from the CHF or from the kidney failure or renal failure, liver disease like liver cirrhosis. And so these are just different scenarios or reasons and mechanisms how the edema would result or form. And then we'll get to the distribution of the fluids in the different compartments. So the first spacing, which is normal distribution of the fluids in the different compartments. Second spacing, which is the abnormal accumulation of fluids that can be resolved with medications or with positioning. If you patient with CHF, for example, if they have the pitting edema, then if you elevate the lower extremities, then that's will relieve some of the edema from the lower extremities. If let's say that if you give Lasix or furosemide to the patient with lower extremities edema due to or resulted from the CHF, same thing. If you give Lasix, going to really cause the urices, and patient will lose fluids, and that will resolve partially or maybe completely resolve the problem with for the edema. So that's second spacing. So second spacings in which that the patient we treat or we attempt to approach or treat the edema, the second spacing with therapeutic modalities like medications, positioning, and so forth, or sometimes even pressure like TED stocking sometimes. So third spacing, all these measures is not going to work with the third spacing, because third spacing is a fluid that is trapped in the compartment or trapped in spaces. Like when we have, let's say, a patient with liver cirrhosis and they had developed the ascites. fluids in the abdomen. So we try partially to give them spironolactone, aldactone as a diuretic medication, but it's not going to be effective only just that this drug to resolve the ascites for liver cirrhosis. We have to do something else. The most effective treatment or modality to treat ascites as a third spacing, this is just an example. I'm giving you an example for third spacing. You can apply this to other scenarios. But the most frequent, you see this, all the time in hospitals, patients with liver cirrhosis, they develop the ascites and the fluid accumulates which accumulated, had accumulated in the abdomen. It's again, the spironolactone aldactone as a diuretic will have a very minimal effect. We give it anyways to the liver, for patients with liver cirrhosis for other reasons and other outcomes. But partially, it can help a little bit with with the abdominal fluid. But the significant benefit or outcome or the result or positive result will come from the, what do you think? Patient with ascites, what would you do for them as a third spacing fluid in the abdomen? How would you treat the patient with ascites? Most effective modality would be
Don't you do like a thoracentesis?
not thorax, it's a paracentesis. Paracentesis, because thoracentesis, that's when the fluid trapped or accumulates in the lungs. Like patients with pleural edema, pleural emphysema, then the thoracentesis can be done for them, or will be the right measure. I mean modality to approach. So the best thing for this patient is the that we consider the paracentesis, trocar inserted in the abdomen, and then we have to physically remove and aspirate the fluid from the peritoneal space. So this is an example of how to treat third spacing. Third spacing has to be removed mechanically and physically from the compartment. Synovial fluid, if there's a lot of fluids in the joint, then one of the best treatments would be to do the aspiration of that synovial fluid. If that's the case that it's causing all these problems for the joint. So that these are all examples of third spacing and the most effective modalities to treat the third spacing problem. And then the hypovolemia and hypervolemia, we went over this in in pathophysiology, because I was gonna leave some time to discuss the case studies as we are trying to apply all these concepts in the case studies. So hyper versus hypovolemia, or fluid excess versus the fluid deficit. And we treat hypovolemia with balanced IV solutions, isotonic or blood transfusion, depends on the scenario. Potential complications is hypovolemic shock. That's from the potential complication from not the treatment, that from the hypovolemia itself, as as like untreated hypovolemia. The fluid excess or hypervolemia, we give diuretics, and we went over this a few minutes ago, and we said we can restrict fluids, like patients with renal failure, patients with liver cirrhosis, patients with certain diseases that we have to restrict fluids for them. And fluid restriction, what is the best way to restrict fluids? Because we shouldn't be saying fluid restriction should be the same for all patients, like we have blank statement, 1 liter of fluid for fluid restriction as an order for all of them. What would be the best strategy to consider for fluid restriction? given all the differences between patients' weight, patients, level of the, or degree of the disease process in the disease process, or the phase of the disease process, the patient's weight, patient's height, all these differences and other factors. So you don't want to give like blank state. I mean, this is seeing sometimes in a clinical setting is that they will say one flow or 1.5 liters of fluid restriction for all patients. But what is the best and the most effective strategy to use for fluid restriction?
Could it be measured the intake and the output?
Right.
Patient?
Right. So good. So that we will have in consideration of the intake and output, and we are going to use the output as the scale or measure, or let's say the patient's output is 700. And we always have, we'll add 500 or 600. Some textbooks, they will say 500, others will say 600. So it's between 5 and 600 on the top of the output. And that's the best way to, because it has to be based on the patient's output, not just a blank statement that, just 1 liter fluid restriction for all patients. So it is a patient specific when it comes to a measurement or strategy to consider for fluid restriction. So patient's output today is, let's say, so we'll do output for a few days and then we'll take the average. If the average is 700, and then I will add 500 to that, and that will be, patient will be on fluid restriction no more than 1200 mLs a day. If the patient's output is a 500, then I will add another 500 or 600, then it will be 1000 or 1100 fluid restriction. So based on the patient's output, that's the best way to measure the fluid restriction. And potential complications, as we know that patients, when they take too much fluid excess, the first thing comes to your mind or think about is the pleural or lung, sounds, right? You're looking for the rheals or bronchi because of the could be patient had developed the pulmonary edema, and then the fluid in the abdomen, which is the ascites. Electrolytes, we know the ranges of each electrolyte and the sodium, potassium, and calcium. Sodium, hypo and hypernatremia, signs and symptoms, how to manage that. Potassium, we always we stress much on potassium. We always make a big, significant consideration of the administration route, or the dosage. We make sure that potassium is not going to be given IV push under no circumstances. That has to be diluted, and you will find that the pharmacy now in all hospitals is going to deliver or prep that for you. So it will be sent from the pharmacy, diluted, and it will provide you with a label on how many milliequivalent in the bag and so forth. So, and it will be always given, if it's intravenous, then it will be via pump. So it has to be calculated through the pump, and so never given IV push, because that results in cardiac arrest.
Dr. Mickey, on the previous slide, you have stored blood and then a question mark.
Yeah, I explained that earlier about the stored blood is that's going to result in releasing more potassium in the plasma, and the patient will develop the hyperkalemia from the destroyed RBCs. So that's especially from the, from the the destruction of the RBCs results in hyperkalemia. And so hyperkalemia or hypo, both of them, the most significant complication would, would be the dysrhythmias, like ventricular fibrillation, cardiac standstill, which is cardiac, standstill, or a VFib. These are the most serious complications from, or EKG changes you would experience, patient experience from hyperkalemia. The hypokalemia, which is the potassium less than 3.5. It says here increased digoxin toxicity. So, and this is one of the most important concepts in mid-surg when it comes to potassium and digoxin. Patients on digoxin, we need to plan, like frequent electrolyte results. So we need the potassium level to be done at least, like, every, let's say 3 or 4, or it depends on the case, maybe 3 months or 6 months, but we need like frequent electrolyte review, or results. So if the potassium is less than 3.5, we have to hold digoxin that day, because the hypokalemia will trigger the digoxin toxicity. So that's the sequence, or that's the direction. It's the hypokalemia that is going to trigger the dig toxicity. So anytime the patient's potassium level is less than 3.5, make sure that you hold the potassium that morning.
Sorry, it triggers
Digoxin,
triggers.
hypokalemia. It will trigger and precipitate the digoxin toxicity.
And then you said hyperkalemia, it would produce a dysrhythmia problem?
Yes, actually both the hypo and hyperkalemia will result in dysrhythmias. But with hyperkalemia, it's more dangerous than the hypo, because the hyperkalemia will result in the VFib, which is life-threatening dysrhythmia, as we discussed this in about 2 weeks, and the cardiac standstill. It's like straight line, like patients, heart will stop. So that's why the hyperkalemia is more dangerous than the hypo. Both of them will result in dysrhythmias, but the hyperkalemia will cause the life-threatening dysrhythmias. And then the calcium, the hypo and hypercalcemia. Yes, go ahead.
You said that when the potassium is less than 3.5, we hold the digoxin or the potassium?
No, we hold not the potassium. You hold the digoxin. Patient's potassium level is 3.5, and digoxin tablet is, scheduled to be given that morning. Hold the digoxin that morning. And probably that, this patient was on, what would be the scenario of this? Who can think of a scenario of a patient on digoxin and potassium level is 3.5? Why do you think the potassium, dropped that low, 3.2, for example? What makes the potassium to drop to 3.2? Just think of, other medications, think of other scenarios of what would, make that potassium to drop to 3.2. Which medications will make the potassium to drop? It lowers it. And that's why we have to make sure that every time you prescribe this drug, you will always add next to it potassium supplement.
A diuretic or no?
Right, which is specific. We have 2 different types of diuretics. We have the potassium sparing, like aldactone, spironolactone. It will spare potassium. We have another sets of drugs like furosemide, Lasix, they are potassium losing diuretics. So it will, when you give Lasix or furosemide, automatically it will flush more sodium, more potassium from the blood through the kidneys, given the mechanism of action of the drug on the kidney tubules. So more potassium will be flushed because the patient is receiving the furosemide Lasix. So furosemide Lasix, 20 milliequivalent, or furosemide Lasix, 20 milligrams or 40 milligrams. We always, and sometimes overlooked, and even practitioners, sometimes will overlook this, piece, which is to prescribe potassium supplement. If you prescribe 20 milligrams of Lasix, right next to it, right away, 10 milliequivalent of potassium. If patient is receiving, let's say, 40 milligrams of Lasix, especially when it's IV, Lasix IV, then you will give about 20 milliequivalent of potassium supplement daily. So daily Lasix supposed to be in conjunction with or concurrently, patient should take the supplement of potassium. Otherwise, they will be hypokalemic.
So the
So this,
patient,
yeah,
the patient will be able to take the Lasix and the digoxin if they take the potassium supplement.
anytime you prescribe Lasix, think about the furosemide, the Lasix going to, patient will lose potassium, regardless of if the patient is taking, digoxin or not. It's let's say, no, this patient is not taking any digoxin. Still, anytime we prescribe Lasix or any medication that would result in the loss of the potassium, especially when it comes to potassium losing diuretics like furosemide Lasix, make sure that, because we know the patient is going to lose, lots of potassium, then we have to supplement that loss with another medication. So potassium supplement should be prescribed anytime we prescribe the patient daily potassium losing diuretics like Lasix. And that's you can apply this to any medication similar to the furosemide, not just the Lasix, but any medication that's similar to that furosemide, then we make sure that we give potassium supplement. So now the next step is that, let's say that this patient is on taking the Lasix that morning, furosemide, he or she is not taking any Lasix, potassium supplement, was overlooked by the practitioner or the physician. You will see it all the time. You will see this in the hospital all the time. Patients on Lasix, not on potassium. And then what happens is that that morning their potassium level is 3.1, 3.0, and then we have to give potassium run or 2 potassium runs of IV. So and given that if the patient also on digoxin, then that could result in digoxin toxicity because of the hypokalemia. See the connection? See how that mechanism? And it's a little bit complex, but this is one of the classic scenarios you're going to see in the hospital. You may not see this specific one, which is digoxin, because it's not widely used as used before. Before the advent of the new medications, we used to see almost like most of patients, not all of them, with the heart failure and other cardiac problems, they will be on digoxin. But now it's not that, I would say frequently used or widely used because of the advent of the new medications that had replaced the digoxin. But this is one of the concepts was still, I would say one of the most important concepts in med-surg about the potassium sparing, potassium losing, and especially if the patient is also concurrently taking a medication on the top of that. That makes it even worse, like the digoxin. So patients will not develop the toxicity if we take care of the potassium loss by replacing that with the supplement. So the last electrolyte, you will hear more about the magnesium and OB, given the function of the magnesium in in uterine contractions. So we'll hear about the magnesium more on OB. Here it's the calcium. So hypocalcemia, and we know that when the patient develops the hypocalcemia, there are two manifestations or two features of the hypocalcemic patient, that they will have the Schwastek and the Trousseau signs. And we learned this in the patho, right? About the hypocalcemic features or signs. One of them is called Schwastek sign, and the other one is Trousseau sign. Carpal flexion or palmar flexion with the inflation of the cuff with the blood, sphygmomanometer, or the cuff with the blood pressure machine, and the twitching and the spastic or switching of the muscle of the cheek as we tap on the cheek. So that's the Schwastek sign, and this is the Trousseau sign. These are consistent with hypocalcemia. So anytime the blood, the plasma calcium level is less than 9, at some point patient may develop these two manifestations. Protein imbalances, mostly we will focus on the loss or the deficiency, not the hyperproteinemia, but mostly we would see patients with a hypoproteinemia. It's not that that frequently that you will, or like widely kind of seen scenario of hyperproteinemia, unless the patient is receiving like TPN or PPN, parenteral nutrition, and that could result. But mostly we'll see patients or cases or scenarios of hypoproteinemia, starvation, malnutrition, and so forth. These are from, I just extracted from the ATI textbook. Any questions before I go into the questions? And we have also scenarios or case studies, which I will give the assignment after we are done with these questions, so you can discuss them on your own. And that now these case studies or scenarios in which that you will do them per group or within the groups, that will be posted in Blackboard. It's questions and answers, so you will answer the specific questions, not like the genetics, more of work questions. But I think I wasn't looking for a correct and wrong answers, but now this is different, given that the genetics it's based on the principles of like ethical, legal, and it's mostly ethical discussions. So that's why there were no right or correct answer. But with these case studies, I would explain the assignment at the at the end after we are done with these questions. So let's take a guess for yes.
So you said for hypocalcemia, the patients show signs of Trousseau.
Trousseau, just this one right here.
Yeah. When do they appear, those signs, or like how do they develop?
Okay, the Trousseau sign. Can you see it?
Yeah.
See the Trousseau sign? Yeah. See the blood pressure machine, the
Okay.
sphygmomanometer, right? You see it? When
Yeah.
you inflate it, you see how the fingers are flexed.
Yeah. So when they put
The flexion, you see significant flexion, carpal. They call it carpal or palmar flexion, palmar, and carpal flexion of the palm and the fingers.
Okay.
That's how would you stimulate the the sign. And then the Schwastek sign That's when you tap on the cheek.
Okay, thank you, Dr. Mickey.
You're welcome. Okay, so let's go to the questions, and then after that, I will explain the assignment for, the group discussions, and for the upcoming discussions, or case studies. I will be posting the answers right after the due date. So they're due next week or the end of next week. Then right after that, after you submit your answers, then I will post the answers to the rest of the, for the entire class. Okay, so let's take the first question. I'm going to to call according to what I have on the screen. Page the first one, please.
What is the best way to determine the water balance in a body? I would say best way to determine water balance in a body. I would say C. I'm between B and C.
Right. Yeah. Most of the students will go between B and C because B will always stress a lot on the intake and output and the daily weight. So daily weight it is. Daily weight changes or change, especially when it's a sudden change. So the most significant or determinant of the body water balance would be the weight change or daily weight, especially when it's a significant change of daily weight. It's an excellent indicator of overall fluid volume, either it's loss or gain. So C is the correct answer. 2 would be Shiskaro, please.
Okay. Which patient is at greatest risk for fluid and electrolyte alterations and homeostasis? So I'm in between B and C. But I would probably say B.
So the middle-aged man with vomiting 5 times versus the infant diarrhea 5 times. Remember that who would be more affected from fluid loss? The child whose most of their body under the is fluids, or the middle-aged vomits 5 times?
Child.
Right. So the infants are at increased risk because their water content is about 70 up to 80% of their body weight. Right? So A is the correct answer. So the elderly also, they have an increased risk, but they have less water content, which is about 45-55%, than the infants. Vomiting, diarrhea, it can produce fluid and electrolyte imbalances because losing fluids, 3 to 6 liters of fluids, they are secreted into the and are reabsorbed from the GI tract. So A is the correct answer. Shandi?
During the post-operative care of a 76-year-old patient, you monitor her intake and output carefully. Why is she at risk for electrolyte imbalances? I would say maybe D.
Right. And and the older adults, the body water content average about 45 to 55% body weight. So D is the correct answer. Shaniqua?
Can you hear me clearly?
Not really. Yeah, it's okay. You can fix it later on because it's still a little noise going, you know, or echo from the noise. Yeah, it's okay. Kaylin?
The patient's laboratory results indicate a sodium level of 133 milliequivalent per liter and a potassium level of 3.3 milliequivalent per liter. The nurse practitioner orders only potassium replacement. What is the best explanation? Is it A?
Right. Yes. Yeah, the potassium is an intracellular electrolyte. So in the bloodstream or blood specimen, only the patient's extracellular level is being measured. What we can measure actually is just the extracellular, which is you know, the plasma level of potassium level in the plasma. We cannot measure it inside the cells. So that's why the extracellular potassium deficiency reflects much greater intracellular deficiency. So we can tell that, you know, there is a significant deficiency inside the cells, and when we measure it in the plasma, right?
Wait, can you say that again?
Yeah, the potassium is given that it's intracellular electrolyte, but there is no way you can measure it inside the cell. So the level of the potassium inside this, outside the cell, which is in the blood, in the plasma, in the blood, that's like a reflection of the content inside the cell. So if there is deficiency in the blood, or the blood level of potassium is low, we'll definitely saying that it's like mirroring the level inside the cells. So the extracellular potassium, which is the potassium inside the plasma, extracellular potassium deficiency reflect a much greater intracellular deficiency. Deficient in the cells, it's hard to measure. So when we measure it out in the blood, that's our reflection or our approximate, you know, level. That's, you know, it's low in the blood, then definitely is going to be low in the cells. High in the blood, same thing in the cells. So that's kind of the concept here about the measurement of the potassium level inside the cells, which is impossible, or at least it's not feasible at the point when we do the blood testing. When you do the, you know, frequent electrolyte, plasma electrolytes, you cannot measure it inside the cells, but that will give you a reflection of the content of potassium inside the cells when you do plasma electrolyte level. Myra?
What will happen if a patient has a severe deficiency of albumin molecules in the vascular system? Would it be A?
Mm-hmm. So edema would result. Why do you think? How would you explain that, Myra?
Well, from what I remember, I think it was like the albumin levels were the ones that would, I guess, cause like the pull in the molecules inside, so it would cause oncotic pressure.
Good. Mm-hmm. So oncotic pressure exerted or results from the presence of the proteins or the albumin molecules. So when there is a significant deficiency of the albumin molecules, so the fluid is going to leak, right, or exit the bloodstream or the vascular system to the interstitial space. So more fluids would go on to exit the vascular system because we don't have enough colloids, enough albumin molecules to hold the water, so it will leave to the interstitial space. So that's why the fluid will accumulate in the interstitial space, which is called edema. Liz?
What is the proper explanation for the clinical manifestation of confusion in patient with hypernatremia?
Which I missed that concept previously under the sodium, is that when we treat patients with hypernatremia, we try to gradually do the treatment. So it shouldn't be like abruptly we have to lower the level like from 155 right down to 135 or 140. We have to gradually do that because of this. So the answer is
Would it be C?
no, it doesn't have to do with that with the BUN.
Um,
It's about the effect on the brain cells.
okay.
The neurologic symptoms are caused by shrinking of brain cells as the increased extracellular fluid osmolarity pulls the water out of the cells until the two compartments have a similar osmolarity, because both compartments inside of the brain cells and outside of it, which is vascular and interstitial, trying to reach homeostasis. So yeah, I'm not sure if I can find it now. The concept under the sodium, and we said here sodium level at the bottom of the slide, serum sodium level must be reduced gradually to avoid cerebral edema. So that's an hypernatremia treatment as you treat the patients with hypernatremia. And this question, it talks about the manifestations and the fluid movement. So the neurologic symptoms are caused by shrinking of the brain cells as the increased extracellular fluid osmolarity pulls the water out of the cells.
Sorry, can you say the second part one more time? You said neurologic symptoms.
Yeah, the neurosymptoms are caused by shrinking brain cells as the increased extracellular fluid osmolarity or osmolality. So when you see extracellular fluids, which is outside the brain cells, which is in the interstitial and the vascular system and the brain. So it will pull the water out of the cells for one main reason, right? Which is to maintain the homeostasis, which is the osmolarity between the two compartments. So the neurosystems are caused by shrinking of the brain cells as the increased extracellular fluid osmolarity pulls water out of the cells until the two compartments are equal or similar or have similar osmolarity. Okay, next is Marivi.
Which is an example of third spacing of fluid. C, asides.
Good. Yeah. Okay, and next is Mora.
And can you hear me? Yeah.
Yeah.
The patient has a cerebral edema and the physician wants to draw fluid into the plasma space. What do you anticipate administering to accomplish this goal? Cerebral edema. Honestly, I'm not sure.
So if the patient has cerebral edema and you want to pull, take these fluids out or draw them from the plasma space, from the blood vessels.
Would it be 10% dextrose? No.
The 10% dextrose, no, it is a hypertonic, but it's not effective as the mannitol. The best treatment in other scenarios or different scenarios other than the brain cells or brain edema, that might be okay. But for the brain edema, the best and most effective drug to treat brain edema, cerebral edema, is the mannitol. The mannitol. It's a hypertonic solution, anyways, that will draw the fluid into the plasma space. So it will take the fluid from the cells, the brain cells, into the plasma space, because there is swelling of the brain cells, fluid inside the brain cells. To pull them out, you need hypertonic solution. Remember that hypertonic solution? So, which will be right here, this one. So hypertonic solution, you can see it, right? Can you see
Yes.
the hypertonic? Yeah. See how is the cells? Let's say that the cell is swollen. Cerebral edema. This is the brain cell that is swollen. Cerebral edema. And this is the plasma. This is the blood plasma around the brain cells. Blood vessels within the brain. This is the brain cell itself, and this is the blood vessels around it, or out, surrounding the cells in the brain. Now, to pull fluids out of the cell, out of the brain cells, who's became edematous and swollen, we need to pull this fluid to draw this to the blood vessels. So we need a hypertonic solution. The 10% is okay for not for the brain cells or for brain edema, but it's the mannitol is going to do that, because hyperosmolar hypertonic solution is called mannitol or osmotrol. Hypertonic, and is going to pull the fluids out of the cells to the blood vessels or to the vascular system.
So then they would shrink.
Right. At least it will take to result until we see manifestations of homeostasis. Then we will stop the drug. It will definitely take not shrinking, but we need to take the excess of fluids from the brain cells to stop the cerebral edema, to treat the edema and the blood vessel and the brain cells. The brain cells are swollen. We have to take that extra fluid from them, right, out of the cells into the bloodstream. So that's we'll continue with mannitol until we reach a homeostasis or reach normal values, and then we have different measures at blood and lab values to rely on when to start and how much to give and administer the drug and when to stop it. So the problem with the dextrose is that the 10% is hypertonic, but the dextrose, it's usually metabolized right away. It doesn't work as a hypertonic solution to treat these conditions. It's a glucose, so it will metabolize right away, and once it's metabolized within minutes, it will then become hypotonic solution. So it's not going to do the job, even though it is listed as a hypertonic, but just because it's a glucose, is going to be metabolized, and for treatment modalities, it's not going to be effective because it will be metabolized right away and become or be considered as hypotonic once it's in the blood. Okay, 9.
Dr. Mickey, we're past the time.
Oh, sorry. It's 9:74. How many questions do we have? Okay, so we can look at the questions, or get skim through them or read them for next what is that, for Tuesday, and we can start right from number 9, and so that we also, if you have any question about fluid electrolytes or ABGs, and we'll answer that. So any questions before you go to the OB Peds course or class? Any
Wait, did you say
questions?
you were gonna assign something for the groups or no?
Yeah, it's just on the Blackboard, you'll find case studies under fluid electrolytes, and the same groups. You will keep the same group for all assignments. We have 6 case studies. Group 1 will take case study number 1, and so forth. Same. I mean, we just keep going the same. What we did for the genetics, just apply that to